Good morning, everyone, and thank you as well for coming out and making it to this morning's rounds. I'd like to preface that what I mean by complex lower urinary tract surgery specifically focuses on continent divergence and bladder augments and excludes the big hypospadias repair and other surgeries done as well in pediatrics. So in the next 30 or 40 minutes, I'd like to go over some important points, one being what is transitional urology, why is it important? The next thing is I'd like to touch on what transitional urology care looks like in BC and what are some shortcomings and what things are we doing right. And the last but not least, I'd like to highlight some common complications from these surgeries that is hopefully not coming to an emergency department near you, but we may see either here at VGH in emergency or out in the community. So I guess the first thing is, what is transitional care? And it's not as straightforward as referring someone to the next adult provider and in essentially passing the buck or passing their care to them. I think that the definition that really encompasses the necessary components of it is best described above here, which is a purposeful, planned process that addresses the medical, psychosocial, and educational needs for adolescents with chronic physical and medical conditions. And this is when they move from child-centered to adult-oriented healthcare systems. There are many conditions in pediatrics where patients need reconstruction, as I mentioned. One of those would be bladder exstrophy, or in some cases, some kids born with valves will eventually need a bladder augment at some point. But the largest proportion of patients that gets these surgeries are actually those with spina bifida. Advances in medical and surgical care has really led to an improvement in its survival. So if you had spina bifida in 1960, 25-year survival rate was about 25%. Now in 2011, it's 83%, so dramatically increased in that sense. And the improvement may be due in part to multiple reasons. Folate supplementation in food and during pregnancy, prenatal detection, VP shunting for those with hydrocephalus, improved imaging, video urodynamics, for example, MRI, CT, we're protecting the upper tracts better. And this is what I took from, in Dr. McNeely's words, fancy surgeries with fancy complications. So we do all these reconstruction surgeries that, over time we've realized actually has its own set of complications that bring with it. And essentially, issues arise that were not present before as these kids, or now adults, are getting older and older. To date, if you look at this chart, I got this from Health Canada, and they actually keep track of all the congenital anomalies. If you look at 2004 to 2007, which is the most recent one, there's about 100 cases of spina bifida a year in Canada. And fortification essentially meant that at some point, I think it was in the early 2000s, they mandated it that folate be added specifically to flour and rich pasta and cornmeal products. And they believe that in part it contributes to decreasing incidence of neural tube defects, for which spina bifida is part of. How we manage lower urinary tract dysfunction has also changed. First, it was diversion. They all got conduits. Then CIC, and then we CIC and undiverted them. And then there was CIC and augment. And then why not? CIC, augment, and metrophenol. And then we took a step back. CIC and aggressive management with anticholinergics or Botox. And eventually what we do know is that there is some evidence that early intervention is superior to later on. I highlighted in yellow CIC and augment and metrophenol, as these are the patients that are now in their adult age and are likely to show up in the emergency department or adult urologist offices, 1980s and early 90s. And when you look at the patient as a whole and their well-being, and this paper really broke it down well, on the left side, when you look at it as from a health standpoint, from their social and emotional well-being, from their participation in activities and self-management, you see that during their transition into adulthood, which is highlighted in blue, there are new issues or things that arise that in some cases even take precedence than the existing ones. So questions about fertility, sexual function, they want to go to work, they want to move out, and at times they actually forget the issues that were already present at the beginning and still need attention to. Preventing urinary tract infections, make sure they're managing their bladder well. And the end of the day, with these new issues and as they transition, it is not uncommon that they actually don't get addressed or treated because they might not have a healthcare provider anymore that may be very aware of everything that is going on. In the next few slides, I hope to provide you some evidence that highlight the importance of transitional care urology. These are patients that require care for the same issues looked after by the pediatric urologist. I want to show you that patients transition better, actually have less emergency department visits and inpatient admissions. And I want to highlight what issues arise after they graduate from the pediatric center. When it comes to bladder management, the largest data I came across was the experience from Houston Methodist Hospital and their transitional care clinic. They reviewed patients referred from pediatric centers to their clinic, and there were about 24 patients. Average age was 22 years, and follow-up was about 9 months. Primary pathology, half had spina bifida, 9 other had exstrophy or sacral agenesis, 2 had spinal cord injury, and 2 transverse myelitis. When these patients were referred, they got reevaluated again. They got urodynamics done, renal function testing, so serum blood work, upper tract imaging. 19 of the 24 already were doing clean intermittent catheterizations, and 9 of the 24 had prior augments. And when they look at of the 24 patients, 7 required, the ones that didn't have an augment, 7 required either an augment or a diversion with alveolar conduit. And their indication was failed oral or intravesical Botox therapy with a neurogenic, detrusor overactivity, or decreased compliance, or decreased capacity. 5 patients were started on Botox intravesically, 2 on anticholinergics, and 2 on CICs. And if you add this all up, 16 of the 24 patients ended up requiring some sort of intervention after going into this transitional urology clinic. And it just shows you that, in pediatric urology, one of the tenets is bowel management, or bladder management, and continence. And even then, they just graduated. Things have already either gone by the wayside or things have changed to require reevaluation and treatment. There's also data to suggest that patients who are properly transitioned have less ER visits and inpatient admissions. This is a group out of Michigan that did a retrospective review, and essentially any patient that had spina bifida that showed up in the emergency department or their ambulatory clinics or in the hospital were tracked over a 2-year period. And this is because for their big center, it's the same EMR for all pediatrics and adults. 40 of the patients were transitioned successfully, and 61 were not transitioned yet or at all. And yet, meaning they have one pediatric care provider at the age of 29, which doesn't really apply to our system because when you graduate, you graduate. And on the left side, you look at the mean number of visits, 0 to 8. Blue bars represent those that are transitioned and not transitioned, and orange bars represent those that were successfully transitioned. And you can see that, across the board, whether it's ambulatory care visits, emergency department visits, inpatient admission, or surgeries, those that were transitioned well or actually transitioned required, less intensive care in the long run. They took up less resources. They got less sick. And last but not least, there's also new issues that arise for patients as they transition. Erectile dysfunction is common in young men with spina bifida. There was a questionnaire sent out of Boston. We're looking at their experience and their patients with spina bifida, and they saw that about 50% of them had some degree of erectile dysfunction at a median age of 24. A Dutch study also looked at their experience and said only half of the young adults with spina bifida are satisfied with sexual function. And when they asked them what could we have done better, they look at, we just wanted to know some practical issues, like latex allergy and condom use, dealing with loss of genital sensitivity, incontinence and sexuality. And when they're in the pediatric center at age 12, these are questions that may not have popped up yet. Right? But now when it's time to pop up, they no longer have anyone to talk to. And I think that, even though the experiences I presented were from American and other international centers, it really highlights that transitional care urology is something that is good for the patient first and foremost. But in a public system like ours, it may also be beneficial if we keep them out of the emergency department or inpatient wards from complications, and they end up using less resources in the long run. And really, it brings me to the second point is, what do we do here in BC? So at BC Children's Hospital, there's a spina bifida clinic that was started in 1969, and it really was a culmination when a group of interested healthcare professionals got together and sat down and decided that, these are patients that we should, assess together, talk about, and see how we can really improve their care as a whole. It is, for the patient standpoint, so it's also very convenient because it's like a one-stop shop where they show up and they see pediatrics, neurosurgery, orthopedics, urology, and other allied healthcare professionals. A typical day for these patients is quite packed. Imaging is performed, usually an ultrasound, morning of clinic or day prior, and this is all coordinated. If they need urodynamics, it can also be done morning of clinic before they go get assessed. Video urodynamics and gait lab with orthopedics is done in the afternoon. And essentially, patients and families go room to room with the different healthcare providers and specialists. So it makes it convenient, as a lot of them as well, that I will show you later on, is not local or not from the lower mainland. The clinic population, when you look at it over the years, have peaked at about 300 patients in the mid-90s to just over 250 patients now. There are approximately 40 patients as well with other type of spinal cord diagnoses that are followed in this clinic. And essentially, once they graduate, these patients are referred to adult urologists, typically based on proximity to home and ability to travel. There's no formal transition here in BC. We don't have a transitional care clinic like other centers do. So that means patients who, if you look at this model where if they were the hub and the spokes were the healthcare providers, they would come to Children's and everyone would come to them. And now suddenly they have to figure out who's the orthopedic surgeon I'm going to see, who's the neurosurgeon I'm going to see. And on top of it all, they have to coordinate it all by themselves. And I think one thing that also gets left out is as these children get older, mom and dad can no longer look after them sometimes. Or, oops, I didn't realize that I actually don't understand what's going on with me that well. And I can't take care of myself that well either. Sorry. There we go. So in 2016, Dr. McNeely and a team at Children's sent out a survey to 340 graduates, known graduates to the clinic. And response rate, I believe, and I'll show on the next one, is about 17% or 59 patients. Of the graduates, 340 graduates, 41% of them are in the Fraser Health area, 22% are in VCH, some are in the island, and some are in interior health. When the respondents were asked what their health concerns were through this survey, urinary incontinence and UTIs were easily at the top of the list. Bowel incontinence is there in third as well. When they were asked then, what practitioners do you follow up with regularly, you can see that a bulk of their care is now done with, or they see their family doctor the most often. But second on the list is actually the urologist. again highlights to you how important those issues were to them. Then when they were asked what were their barriers to care, and it looks like transportation and travel seems to be the big one from this survey. And I can only imagine how costly it is to potentially come every few weeks for different specialist appointments if they don't plan it well. And when they were also asked, is your inability to see a healthcare professional or specialist, has it led you to come visit the emergency room or have a complication? And 34% of them said yes, and they felt it did. And of those 34% issues that they had, half of them were urologic related, whether they were kidney stones, UTIs, or urosepsis. Then they were asked, overall, were you satisfied with transitioning out from BC Children's to adult healthcare? And a lot of them actually weren't. 50%, half of them were not satisfied with how the transition process worked, which really makes you think, can we do this better? And it didn't matter if they were in their 40s or their 20s. Across all the age groups of the graduates, there was no statistically significant differences between satisfaction between them. Only 39% of them were satisfied with the care they received in the adult healthcare system. So that's strongly agree for this question. And when this graph essentially shows is that it asks patients what their self-reported urologic, neurosurgical, or MSK problems were, and are they seeing the respective specialists that they should be seeing. So for urology, for example, 41% of patients with a self-reported urologic issue were not seeing a urologist regularly. That's the green part of the graph for urology on the left. Urology problems include incontinence, UTIs, stones. Neurosurgery would be VP shunt issues for those that have it. And MSKs would be ambulation, posture, scoliosis for the orthopedic surgeon. And at the end of it all, the importance of transitional care urology in our province is a lack of a formal program led Dr. McNeely and the team at Children's to spearhead a proposal to improve access to care for these patients. The goal is to match the graduates with an effective and interested healthcare specialist within each health authority to make it easier for them to travel. If issues then arise, there's a channel that's open to BC Children's Hospital via teleconference where they can talk about the patient, what the problem is, and then together decide whether treatment should be done locally, wherever they are, or whether the patient should be transferred down. And the other key piece of the puzzle is that there's a facilitator at Children's to follow up with these graduates, with these patients. Because this way, there's someone, in essence, quarterbacking what is going on overall and hopefully keeping them on track. My understanding, the proposal made it to the final rounds of multiple meetings, but fell apart partly due to funding mistake. And in our system, there's many challenges to fund these type of initiatives, no matter how good they might be. One is funding for adult care comes from a different pool. Children's, PHSA, it doesn't matter where you live. But now when you're an adult, you could be Fraser, VCH, and we all know as residents how different each health authority might offer resources-wise. Money does not follow the patient once they graduate. They don't have the government doesn't earmark a certain set of funds that they can for their care that can be accessed as they progress through. And within health authorities themselves, there's lack of funding to establish new clinics, fund nursing support, fund patient navigators, fund allied healthcare providers. These are the things that actually make a difference as well for these patients, and there's just no money for them. This is not unique to BC. Dr. Coyle is at Sick Kids, And he published in 2016 at COAJ a proposal on how to deliver effective transitional care for their province of Ontario. He had a different proposal for how we should do it, but looking at the challenges, it seems quite similar. So for him, he cited as well a disconnect in physician funding, fee-for-service model versus the AFP, alternative funding, I guess, or salary model. And the system doesn't allow for a crossover or hybridized reimbursement. And it's hard for an adult urologist when these patients typically take a lot of time in clinic because their issues are not as straightforward, or they might not comprehend it as well as your 60-year-old business executive that's very high functioning. There's also a lack of desire on the patients and the pediatric provider side to sort of separate long-term care to this new model in the adult arena where it's all different silos. And last but not least, some urologists feel that there's a lack of expertise, or they're not trained enough to deal with these patients. And there's also a lack of interest in some. Really, to summarize, urologic issues are among the top concerns for these patients. 41% of these issues are not followed by urologists, even though they're urologic issues. And half of the patient population is not satisfied with the transition process. And even though we don't have a clinic, I was chatting with Dr. McNeely. One thing that really excited me, or as I think is a positive, since the 2 years he sent these surveys, were the fact that, since then we have Dr. Kavanaugh, Dr. Tran, Ian Wright. We have so many reconstructive urologists now in the fold. And these are typically the ones that end up dealing with these patients. The second thing being, I saw on one of the Lawrence Sullivan Grand Rounds or Research Day presentations where Dr. Southers was doing telehealth medicine, and it was for spinal cord injury patients and UTIs. And to me, if you combine that innovation in some sense, and you have the right specialists, I think it's really a big step forward for this issue. And the last thing really is to highlight some common and selected complications in pediatric lower urinary tract reconstruction. It's quite humbling that selected still means these four things: bladder stones, UTIs, augment rupture, stomal complications. I didn't include VP shunts, which are also common and actually probably the most common cause of death for these patients when they're older. VP shunt malfunctions, if I'm not mistaken. Usually end up with neurosurgery. And upper tract deterioration, as this already touched upon by the first topic with that first. So bladder stones, approximately 15 to 20% of these augmented patients eventually get them. Risk factors that were described, if you use a piece of ileum or colon for the augment versus gastric, and thought to be mucus azonitis for stone formation. UTIs with urea splitting organisms. Mitrophanoff diversion versus those catheterizing with a native urethra, and it's thought to be due to urinary stasis or incomplete emptying. And last but not least, foreign body. And the big thing that was cited was when they used dissolvable staplers was one thing that they had. So this is an example of an actual patient with stones in an augment. You can only see that the emergency department calls you and there's something wrong with the x-ray. So see them in clinic probably is what you would say as residents, but I don't know. So this group from Indiana has probably one of the highest sort of database and amount of augments that's been done in the States. They looked at all their augmented patients, 720 in 2014. Pretty sure it's more now. 15% had bladder calculi. And they managed them in three different ways. Endoscopic management, either whether scope and laser, or they did percutaneous, or they did open cystolithotomy. First stone surgery was performed about 3 years since the augment, and median time to recurrence after the first surgery is about 9.5 or 10 years. One of the take-home points for me for this, and for you listening, if you're in the community, is that There's no difference in recurrence rates between whatever modality you treat the stone with, whether it's endoscopic or open. Recurrence risk is not associated with fragmentation of stones at the time of removal. One thing to note, though, is that the stones that they treat with laser are usually smaller, percutaneously slightly bigger, and open cystolithotomy at the larger size stones. And usually for the percutaneous, they just use a lap trocar was one thing that was described, and they use a nephroscope through it. When looking at urinary tract infections, a lot of these patients are also colonized, so it makes it even harder to determine whether they have a real infection or not. Their perception of pain or discomfort or dysuria is also very different. So one of the suggestions is, culture has to be positive, but they should have some other sort of symptom or sign that there might be something going on. Fever, malaise, flank pain. Antibiotic prophylaxis on its own has not really been that effective, although it helps. And the only data I could see for maybe decreasing UTI risk is Doug Huseman from Mayo Clinic looked at his subset of patients, and he thought that high volume irrigations, 240 mils daily, decreased incidence of symptomatic UTI over a 10-year span in follow-up. For example, 47 episodes in those with 240 mils, 100 episodes in those with 120 mil daily irrigation, and 127 episodes in 60 mils. Each group had about 25 patients each, and no difference in non-compliance between groups. Then there's augment rupture. Incident ranges from 3 to 5%. Causes can be either traumatic or spontaneous, and spontaneous being typically attributed to non-compliance with CICs. High index of suspicion is required. As I mentioned before, these patients have impaired sensation, and they don't necessarily might present with abdo pain, terrible 10 out of 10 peritonitic pain. It should be considered in the patient with prior augment presenting with fevers, sepsis, or no clear source or refractory to initial resuscitation. And the CT cystogram is the initial test of choice, but I think it's happened at Children's, and for this DeFore, I think is from Cincinnati, it's happened to them too, where a negative study happens, and it doesn't necessarily exclude perforation because it could have sealed over, and it results in delayed diagnosis. Same Dr. Huseman from Mayo, they look at mortality following augment, and this is looking specifically at non-traumatic rupture of the bladder. It occurs at about 3%. And 8 of the 13 patients who had a perforation that they had issues with alcohol or substance abuse. Eventually, some even were repeat offenders that they just got an ileal conduit. There's also patients that did not have a perforation yet, but had to be managed by SP tube because they were unable to perform CICs. Part of it is because of the fact that they go into group homes now and no one can do CICs every 4 or 6 hours. And they don't have or they can't do it themselves because as they get older, all the complexities, you just get a sense that, maybe this is someone that shouldn't have been augmented to begin with because they're unable to perform it either mentally or physically. And 2 out of the 10 patients eventually had to have a diversion due to complications, not like perforation, but stones, abscesses, and whatnot. And last but not least, you also can get stomal complications. And this can be cutaneous, and they present with having trouble catheterizing. Channel stricture, also having trouble catheterizing. Prolapse, it can be actually spotting on the overlying clothing and obvious leakage, self-explanatory. And the data I present here is actually our local one from 2008. Blaine Welk, I think, is now in Western. And in about 6% of patients had superficial stenosis, and 3 had dilation under anesthesia and then using a steroid lubricant after. 1 required operative revision. You can get strictures. 2 of them were treated with TUR of the channel bladder anastomosis, and 2 required operative revision. Those that got prolapse, they needed it should be revision at the cutaneous end of the stoma, and then channel leakage is the other thing, 9%. 4 had deflux, with 2 of them eventually failing, and 1 eventually also just wanted the removal of channel, and then 1 went to straight operative revision. To summarize this third objective, really if there was a take-home point, no difference in recurrence of bladder calculi between endoscopic, percutaneous, or open when it comes to bladder stones. High volume irrigation may decrease episodes of symptomatic UTIs. With regards to rupture, you gotta have a high suspicion for these patients, and never, just keep it at the back of your mind always, as it can also kill them. Stomal complications requiring intervention is also common, with endoscopic management common. So with that, at 7:40 almost, I'd like to thank Dr. McNeely, who I've chatted with over several months about transitional care urology, and for a lot of the slides. In fact, there's even a new fellowship in Indiana that bridges pediatrics an extra year of transitional care, and that's just how, I guess, the field of pediatrics, how up and coming, or after doing 3 decades of these complex surgeries, realizing that we should take care of these complications too. And here are my references. Thank you.